Uh, I thank the speakers, the chairperson.
Go on, Saurabh.
Yeah. I thank the speakers, the chairperson, the moderator, and the expert panel for conducting a session which most participants would find relevant and useful. We shall now proceed to the third session of the day, Coronary Live in the Box. The chairperson for this session are Dr. Rabin Chakravarti, Dr. M.S. Hiramat, Dr. Shubhanand Roy, Dr. Sanjeev Sharma, and Dr. B.B. Bharti. The moderators for this session are Dr. P.K. Sahu and Dr. C.G. Baulian. The expert panelists for this session are Dr. Lilo Verghese, Dr. Javed Ali Khan, Dr. Raja Nag, Dr. Pankaj Singh, Dr. Vishal Koftani, Dr. Sanjeev Sidana, Dr. Yogendra Singh, and Dr. Punish Sudana. I request the chairperson and the moderators to take charge of the proceedings. Thank you.
I think. Good afternoon, friends. I'm Dr. Javed here from Raipur Care Hospital. I think the moderator and chairpersons are not available. I think
Dr. Hiramat is there, I think.
Dr. Hiramat is here.
Yeah, I'm here. Good afternoon. This is Dr. Hiramat. I'm in Pune, and it's a real excitement for me to join my friends in East, and we move on with the scientific.
Yeah, Shirish, we are with you, and greetings from East, and welcome to the city of joy, because it's done from Kolkata, and welcome Dr. Javed also. So we can start. Yeah, I'm Dr. Kahali here. Yeah. I have muted because the sound was not coming well, so we muted a little.
So Dilip, we can start with the first presentation.
Technical team, can you? Yeah.
Good evening, everyone. Greetings from Medical Specialty Hospital. I am Dr. Dilip Kumar. My team, Dr. Devapriya Mandal, Sister Dothi, Ajish, and my cath lab technician Arnav and Subrato. So we are going to do a live inbox case recording. And Dr. Devapriya, can you share the clinical summary of the patient?
Yeah. Hello, good afternoon, everyone. I'm here with Dr. Dilip Kumar in Medical Super Specialty Hospital. I welcome you again to this live inbox session. We have here a patient who is a 56-year-old gentleman. He's a known diabetic and hypertensive, and he had presented with complaints of typical chest pain a week back, and he went to a nearby hospital in our city only. And angiogram was done from the center. It revealed a single vessel disease involving the L6-OM bifurcation. And the patient was advised medical management in view of the patient's pain intensity, which was slightly low at that time. Subsequently, the patient had developed increasing intensity of chest pain, and hence the patient was planned for a angio and then followed up by a PTCA procedure. So here we have this patient. The angiogram is shown. We have a L6-OM bifurcation Medina 101, and the plan and the further details will be told by our Dr. Dilip Kumar.
So I think we all can see the angiogram, and we can appreciate the bifurcation disease. And this is something to discuss about this case. This exactly which vessel should be considered as the main vessel, and what should be the strategy. So we have kept our options open as what we will go step by step. This is what is recent consensus in treating the bifurcation lesions. We have become wiser with the recently conducted and presented EBC main at EuroPCR. So we will image both the vessels and then we will decide. Give me the second wire. We will give an injection to, although we will measure through IVUS, but it's a habit that we measure the length of the disease through wire to have a double confirmation. So, can someone take ACT? Okay. So give me the IVS now. Yeah. So it's always a good practice to see it getting flushed here. Sometimes there can be some air bubbles left out. It's crossed. So now we can start imaging and so
Screen.
it's there. So the vessel size looks to be, now you can appreciate the size. It's 2.25, 2.5, not 2.75. Disease at the ostium, although we will have a separate run through that vessel as well. So
This is
here
the other
I-
vessel?
better. Oh, we have lost. We missed that, huh? Okay. Okay. So there was a, it means there was a significant disease. Can we review the IVAS? Let's take it out. Let's start imaging. Size looks good. It's definitely 2.75, 3-ish.
The OM.
This is the disease. Yeah, can appreciate this ostium is diseased. And this is the, so this is a significant disease in the ostium. Okay. So what was not clearly seen on angiogram, we are doing saying something like 101 came out to be 111. So this is the importance of imaging. Now we are clear that we have to maybe deal with 2 stents. 14. Down. So there can be discussion about the stent sizing and which strategy. So in apparently small vessel bifurcations, I see it is our maybe practice that we do more often a pull-out or a mini crush. Rather, pull-out is the preferred one which we do. But let me go, then we go to OM first. Give me a 2.75 24 stent. Onyx. Yeah. At the ostium only there was disease, so this place looks good. Okay, please go. 4, 6, 8, 9. Okay, please go. 10. 10. Okay. Down. Go little caudal. So that caudal. Little elbow. Yeah. You can see the stent better. Go. 10, 11. We can use the same wire which we had taken in, or so we'll take injection so that we can clearly make out, considering the mismatch in the size of the vessels. Better to do a tap and come out. Had it been a similar 2.75 milliliter vessel, culotte could have been more reasonable. So now I'm going to dilate the strut and then we'll take a stent, maybe a 2.25, because the distal vessel we again reviewed. Can you show me the IVAS again? So we are dilating the strut. So all along the procedure, we have kept our strategies changing. Right to begin with, we had no idea. We had an idea that the OM ostium was probably disease-free. Imaging showed otherwise, and then we thought we'll do a plot, and we stented the more angulated branch. But now we are going for a tap strategy. So many times it happens when your wire goes through the jail segment in a smaller segment and then go in the main vessel down. Then your balloon may not track. So we'll rewire it. Okay. So let's see whether we can take our small balloon down or not. So it had gone between the stent and the vessel. There's no reason why it shouldn't track a small balloon. Now we'll take a stent and a balloon which will be parked inside the OM and we'll do a tap. Okay, so we have parked it in the main vessel and then we'll take the stent through the... We have to be careful here that we have to see it in multiple views. Otherwise, there can be... Okay. Okay. Show me. So you can appreciate that we are going in cine. It looks fine. Hold on. We will withdraw the balloon, main balloon here, so that we can kiss it. Okay. Okay. Maybe a little more down, up, down. Okay. Okay, show me in the different projections. So where you see the side branch coming perpendicular gives you a better idea. I think we are well placed. Okay. So this is stent. Okay. Okay. So here we'll go and please go. Pardon? So here we'll go. You can appreciate hardly one or two studs are there. Okay, go, please go. Go. 11. Okay, it's all right. 10. Okay. So go epicaudal, main AP, plane AP. Come down, down, down. Deflate. Go kissing. So the one. Okay. Negative. Negative. It's all right. So our job is done. Giving some vasodilators. So it looks fine. Hold it here. So there is some. So it looks perfect. We'll do a pot, then we'll do a final imaging run. Give us the 3 balloon. Go, it's all right. It's all right, it's all right. Go, go, go. Please go. Yeah, it's good. 11. So I will take the wire because wire spasm will go away. Give me the final imaging run.
You have it.
Yeah. So it's a wonderful position and appreciate. We'll see. Look at the carina, how it looks like. Well expanded stent. Yes. Good MSA as well. little under expansion, but yeah, you can see the yeah, can appreciate well expanded proximal stent. So we got an MSA of 7.1, and we left it there, and we can start the discussion, sir.
Dr. Dilip, this is Dr. Sanjeev Sharma, Jaipur. Did you initially started with a single stent strategy, or right from the beginning you had a?
No, we had our options open, and we imaged both the vessels, taking the IVUS separately, inside the both vessels. So it's always, a good idea to go inside the, take the IVUS run both separately in different vessels and then come out. Suppose the main vessel you are going down and then you are looking at the ostium of the side branch through main vessel IVUS. It may not give a correct idea. So we did the imaging runs through both the vessels, and we got to know that the plaque burden at the ostium was more than 50%, the OM, and OM was a larger vessel, and the circumflex continuation was more diseased. So this made us change our idea, and we thought of going a two-stent strategy. Initially, the angle was less than 70. We thought of doing a culotte, but the size which we saw in the IVUS was not good. It was 2.25 distally, and the main vessel was around 3, and the OM was around 2.75. So we changed it to a tab technique. So this is all what we went through while doing the procedure.
It's a nice result and a nice demonstration of TAP technique. But the size of the vessel, 2.25, 2.5, in such a smaller size, rather than putting a 2 stents and making Karana with a metal, it would be better to go with a single stent and then do a kissing and see the result. If that is you have a suboptimal result, then you can plan for the second stent. I think the provisional stenting would have been a first choice in such a small vessel rather than putting a 2 stents.
So the single stent will go straight down in the lower OM?
Yeah, that is what also we thought we would go like that, but the imaging changed the entire scenario. We clearly showed there a plaque burden of more than 50%. We thought if we stent from LM to a straight vessel down, there will be a significant plaque shift, and we'll get a disease there, and we will have to do something. So from beginning.
Dilip, I think the strategy of single was not that bad in this case, because you had an imaging which showed you a plaque burden on the side, but stenting the straighter vessel and then thinking about a tap if required could also have been a strategy in this. Because ultimately, you didn't go for any committed stenting.
Right, and part of the decision making was also, as I was doing a live in box. So maybe a simple day-to-day case, I would have done a plain angioplasty and come out a single stent. So we had to go meticulously, and plaque burden we couldn't have ignored in that vessel.
Did you do pot? You didn't show pot before recrossing into the distal part. Did you do pot?
शाम को 7 बजे है ना तुम्हारा?
Dilip, did you do a pot before crossing back into the distal L6? You didn't show that step. You did pot.
Yeah, it was there.
But then you also thought that the wire has crossed from between the stent and the vessel.
Yeah, after we did the pot, we rewired with the OM, the wire into the circumflex continuation, and I think at that small point it was through the struts, and the small balloon was not going in. So we rewired that vessel, and that everything was smooth.
Before rewiring, what would have been the step is to redo a pot. Because had your pot been adequate in the proximal vessel, this thing cannot happen. Or the other way is that if you've done a pot, you're very sure that you can't do any further. And taking a loop wire would definitely make sure that you're not passing through strut. And try to take a more turn to the wire so that a loop goes in. But that's not required in this case. I think a repot would have made sure that you definitely in the second run also don't cross it. Because keeping a balloon in the stented vessel is not better necessarily.
You are very right.
With step for tap. Once you have put the stent, you can just open the strut of the balloon, that stent, and then do STB.
Dr. Sanjeev, if you have a main vessel OM branch wire and you withdraw it till the carina, you are not coming out, and then you are reintroducing into the main vessel, then the chances of going through strut is very, very,
very less. No doubt. Yes. So you did that.
With this idea, we had done the pot and we used this strategy. Even with that, our wire balloon was not going in. That's why we rewired. We had done, enough.
But I think I would like to make one comment. Forget about that. I think if you look at this case, the main lesion was the lower branch, that is the most critical, then the upper branch. At the same time, the upper branch is actually subtending to a bigger area of myocardium. The lower branch is basically in the left atrioventricular group. So if IVAS shows that in the major branch there is significant, so that has to be addressed. So in that situation, because angiographically it looks like you could have done with a single stent to the lower branch, but once you have IVAS that there is a significant plaque, and then there's a chance of further plaque being shifted from the smaller branch to the bigger branch, I think it is quite reasonable and quite acceptable to have a two-stent strategy in such a case.
I would also entirely agree that the IVAS, you decided two-stent strategy, and the strategy which you adopted too was absolutely perfect. So I would put a bigger diameter stent in the bigger vessel from proximal circumflex to the upper OM, and a smaller diameter ST. I think it's in such small diameter vessel, it is better to avoid culottes, because the overlap of two stents, I think most of them would be 0.7, 0.8 in thickness. That would itself take away a sizable lumen area. So I think I would also agree that in this kind of small diameter vessels, better to avoid culottes and put the way you put the two stents.
Right, sir.
Dilip, get your point.
Dilip, I just want to comment one more thing. As Dr. Hiramat rightly said, that in small vessel, I mean, you should have planned right from the beginning to do either the mini crush or the tap, what you have done finally, rather than going for the cuvette right from the beginning. So your decision was right finally, that you have done the tap, and the result was fantastic. Great.
The only thing which was guiding me was less angle, sir. It was something like 50, 60 degree angle. So that's why that was the idea, working on me to go for a culotte. And in my experience, in my practice, we have seen more distal vessel is there. The culotte becomes easier to do. So these are two rationalities, and this was the idea.
One thing, Dilip, if you had taken out the wire of OM and taken that into distal 6 and still the balloon didn't go, and that means one thing is for sure, it has nothing to do with your pot. Because if you're saying that you first tried taking out the OM wire and putting it to distal LCX, and then you had to recross and you were able to cross, that very clearly shows this has nothing to do with the proximal optimization. Probably had to do with some angle, because then you can never go to the stent that would taking of the wire would,
At carina, where in pot you leave the carina 1 to 2 millimeter, and then you pot the upper segment. You don't have to go inside the main vessel, the distal branch of the parent vessel, and that is the idea about pot. And then you can miss 1 or 2 struts, and that was probably what happened there. In 1 or 2 struts, it went through the jail segment, and that's why my balloon was not going in. And once I rewired, it went very smoothly.
I think these are pretty standard steps, like you wire the side branch. If balloon doesn't go, you try and access another strut through which the balloon might go. I think that's what it was finally. And I would entirely agree that if the balloon is not going, we should not sort of try and force. Many people are worried that the side branch may not be accessed with a wire again. But I think taking another wire is probably the easiest way to handle it.
And is there any strategy you think about a distal cross or a proximal cross? Do you try to find out with the imaging that you've definitely crossed for a tap or a distal, or is it that it's the ease of cross once you check crossing of a smaller balloon, or is it that you
I didn't go for that.
try to make sure with an imaging that I would still cross first time?
No, in such a small diameter vessel, I think it's pretty difficult to search for a distal cross or a proximal cross. I think whatever goes, accept it. Of course, try for a distal cross, but wherever it goes, and if the balloon doesn't go for the cross.
I think we are running out of time. We should move on to the next live inbox case.
Please.
Everybody, welcome to Ashwini Cooperative Hospital, Solapur. At the onset, I would like to thank the organizers for giving me this opportunity to present this case of complex PCI. This gentleman, he is a 70-year-old gentleman. He had a past history of hypertension and he presented with acute coronary syndrome. He has history of angina off and on for last 6 months. There is no history of diabetes. He is not a smoker. The investigations revealed a normal sugar. The creatinine was 1.8. The troponins are elevated. Trop T is 444. And echocardiography revealed regional wall motion abnormality in the inferior and lateral territory with mild left ventricular dysfunction. The ECG showed significant ST changes in inferior and lateral leads. With this background, he was taken for angiography. As you will see, it's a triple vessel disease with a very long segment LED lesion to the tune of 95%. Then there is a total occlusion of the circumflex proximally with no antegrade flow. And there is a long segment chronic total occlusion in the mid part of right coronary artery. The syntax calculated score is 24.5, the Euro score is 19.55, and he is a high bleeding risk candidate with Has-Bled score of 3. Now, syntax score being 24.5, he was given, his relatives were given the option of both CABG surgery and multivessel PCI. The relatives were also explained about the CTO RCO, which may or may not be opened by angioplasty. And despite this, considering his age, the relatives were very reluctant to go for CABG surgery. So the plan was to open up LAD and circumflex. Circumflex was presumed to be acute because of the troponins were significantly elevated. The RCA, then attempt was to be made if the time and the contrast permits. Otherwise, RCA-CTO was to be tackled at the later stage. With this background, he was taken up for angioplasty of LAD and circumflex. Good evening, everybody. Welcome to the cath lab of Ashwini Cooperative Hospital, Solapur, Maharashtra. I am Dr. Gurunath Parade, Senior Interventional Cardiologist and Chief of Cardiology at Ashwini Cooperative Hospital. Before I begin the case, I would like to introduce my team. This is Dr. Shailesh Patil. He is my colleague. This is Dr. Kalshetty. He is the anesthesiologist. He is on standby. This is Mr. Anil. He is the Chief Cath Lab Technician. And this is my team, other team with all cath lab technicians and nurses. Coming to the case, as you will see, this is a 70-year-old gentleman with high bleeding risk. He has a 3-vessel disease. His syntax score is 24.5. So naturally he is a candidate for either CABG surgery or a multivessel PCI. These both options were offered to him. In fact, CABG surgery was the first option which was offered to him and the relatives. But considering his age and the high bleeding risk and the elevated creatinine, the relatives were reluctant to go for CABG surgery and they had some prior bias against CABG surgery. So they decided to go for a multivessel PCI. this is in spite of the fact that, as you will see on the angio, the right coronary has a chronic total occlusion, a long segment chronic total occlusion, and I am not sure whether I'll be able to open it. So I have explained the fact to the relatives that I'll be definitely be doing LAD and circumflex, and the CTO of right coronary will be attempted later in a later stage, not in this stage, because the contrast may not permit. The patient has a elevated creatinine, so his symptoms will be relieved. The circumflex artery proximally, as you will see, is totally occluded. As the patient has presented with acute coronary syndrome and his troponins are elevated, I think that this vessel is acute and I'll be able to open it. My first plan is to open LAD. You will see LAD is a very long segment lesion, very tight lesion, and at the level of septum, you have nearly 95% occlusion. My only worry about the LAD lesion is whether a single stent will be supported in view of the long lesion. So this is my plan. So first I'll wire the LAD. Now this shoot you will see is a very long segment LED lesion. Now I have decided to use extra support whisper wire. Yes, with some manipulation, I am able to cross the wire into the LED. Now the balloon which I have used for pre-dilatation is a Solaris balloon, 2.75 by 15 millimeter Solaris balloon used, and multiple pre-dilatations have been given, and you will see some dissection at the level of septal. That's good. So I straightway decided to go ahead with stenting. Now the concern, as I expressed earlier, whether a single stent will be can cover the full lesion and will be supported by the guide, or I may have to use two stents. But you see the Resolute Onyx stent has tracked very easily. This is a long 2.75 millimeter by 38 Resolute Onyx. This has tracked very easily without much difficulty and is able to cover the lesion fully. Now this has been deployed at 12 atmospheres. And you will see the result is good. All the diagonals and septals are well preserved. None of the side branches have been lost, and the flow is T3 brisk. Now the post dilatation is done by 2.75 millimeters by 15 distally and 3 millimeters by 12 millimeters proximally, and you will see a good result. Having taken care of LAD, now I move on to circumflex. You will see the circumflex proximally is totally occluded. Now the same wire, I have used one more wire now. With that wire, I am trying to cross the circumflex. There is some resistance. Circumflex is coming nearly at right angles to LAD. With some manipulation, I am getting the wire slightly move forward, but I don't know whether it is in the main vessel or in the branch. So I have changed the wire. I have removed the wire from the LAD and again tried with this wire. This is again a whisper wire. This wire with some manipulation, yes. Now this wire crosses into the main circumflex, and this is what the main circumflex is. So after crossing into the main circumflex, dilated with 2.5 by 15 Solaris balloon again, and you will see the vessel is been well opened and you are getting a good flow. I have done even aspiration using a thrombus aspiration catheter. So whatever the thrombus, because this was an acute case, and sometimes I have noticed that in acute case you tend to have slow flow, no flow after stenting. So in my usual practice in all acute coronary syndrome, especially STEMI cases, I tend to do thrombus aspiration to avoid this slow flow, no flow after stent implantation. So after that, now this is a stent. The stent which I have used, you will see the distal vessel is slightly small. So the stent uses 2.25 by 26 millimeters. Again, resolute onyx. You will see the vessel is slightly tortuous. So I think the onyx stent is ideally suitable for this lesion and will track easily. Now you will see there is some mild disease at the ostium of circumflex, and we debated whether we should stent the vessel from the ostium. But at that moment of time, I didn't want to make the procedure very complicated, because if the LAD ostium is compromised, then perhaps I may have to do a very complex bifurcation procedure. And this patient with who has already dye limitations, and with that I don't know so how much the time and dye will be required, and I might unnecessarily complicate a simple procedure. So I have decided to stent this vessel after the ostium. You will see there is a nice healthy part of the circumflex. There is mild ostial lesion I decided to leave, and this is stenting. So the stent has been deployed at 12 atmospheres, 2.25 millimeters of the onyx stent, 2.25 by 26 millimeters onyx stent has been deployed. But this was a rather unpleasant surprise. You will see there is a proximal dissection, edge dissection just proximal to the stent. Now, in fact, earlier I wanted to avoid touching the ostium, but now I have been left with no option but to stent from the ostium. Initially, my colleagues thought that this could be thrombus. So a thrombus aspiration catheter was passed and tried to aspirate, but there was no improvement. Then the balloon dilatation by 2.5 balloon was dilated from ostium into the stent, and you see the result is good, and virtually you don't see any flap there. But after some time, in caudal view, you see some haziness. So now you cannot leave this vessel, and in the meantime, patient started having some arrhythmias, some STT changes, became restless, mild chest pain. So this, I didn't want to take a chance, and naturally this ostium of the circumflex needed to be stented. So a small stent, 2.5 by 12 millimeter onyx resolute, I decided to place from the ostium into the stent. So this is it, but you will see that stent is not able to go across into the circumflex. So I took out the stent, decided to post dilate the circumflex. Now I post dilated the circumflex stent with 2.5 millimeters. So 2.5 by 15 NC balloon, I post dilated the circumflex stent so that the stent should get well opposed to the vessel wall. And now took the 2.5 by 12 onyx resolute again, and now you will see the stent has easily passed. Now I used a technique similar to TAP because I didn't want the LAD ostium to get compromised. Now there is no stent in left main and ostium of LAD. So this is not exactly TAP. But what I have placed a balloon, this balloon is 2.5 millimeters balloon. The LAD vessel, which we know the stent is 2.75. So I used a slightly lesser sized balloon, lesser diameter balloon into the LAD from left main to LAD, protecting the LAD. And I inflated the balloon before deploying the stent. I used slightly lesser diameter of left main to LAD so that the stent after inflation should not slip back into circumflex, and it should be exactly placed at the ostium. So after inflation of the balloon, you will see the stent has been pulled slightly proximal to the ostium so that the ostium is not missed. But at the same time, the care is taken because another balloon, inflated balloon is LAD. So the LAD ostium will not be compromised. So this is a technique which I use to protect the LAD ostium. And so this again stent is deployed at 12 millimeters. And again, the stent, you will see there is a good flow. The balloon has been kept into LED. So because at the time of post dilatation, again I had to protect LED ostium. So the NC balloon 2.5 again has been taken into the circumflex, post dilated at 20 atmospheres from distal to proximal. And at this post dilatation, when at the time of post dilatation of ostium of the second stent, again the balloon is inflated from left main to LED to protect LED ostium, and so the procedure is done, and you will see after removal of balloon the LED ostium is not at all compromised. The LED is flowing well, circumflex is flowing well, but just to be sure, I did an IVUS of LED, and you will see this IVUS run, and the LED ostium here you will see the area of LED ostium is 6.5 centimeters, which is good, and the left main is clean, and the patient's symptoms, ECG changes also have settled, and because of the dye limitations, I have decided not to attempt the CTO of RC at this moment, but to do it at a later stage. Procedure initially appeared relatively simple, just doing LED and crossing an acute total circumflex lesion. But this was complicated because of the edge dissection and the dissection extending to proximal circumflex. And I had to do a sort of a modified sort of a bifurcation technique to prevent the LED ostium getting compromised. But in the end, result was good. Thank you.
Hello.
Yeah.
Yes, sir. One thing is that RCA was 100% occluded, and from operator were knowing from the beginning that the L6 is acutely occluded. Still, he tried LED first rather than the L6. The reverse could be better, because if something happens with the LED, like sudden occlusion of the LED, patient was gone actually. So if somebody who will try the LCX first and later on LED, could be a better idea to supply at least some of the myocardium of which is supplied by LCX. Opinion from seniors.
I think I would entirely agree with this, because right from beginning, Dr. Parare was talking of LCX as an acute occlusion.
Yes.
And under this setting, I would go for the acute occlusion first. Patient coming to cath lab, acute, you must fix before we go for the other vessels. But I guess the LED is such a big vessel in this case and was supplying the entire territory, which is covered by RCA and to some extent the LCX2. LED was very crucial artery, and probably you preserve your best stuff for the LED, and that could be the thought behind such a seasoned operator as Dr. Gurnath.
There is one more thing. After dilating left main to LED with a bigger balloon, I don't think we should have left it like this. We should have done a dedicated crush. Basically, we should have crushed this stent in circumflex ostium with the left main to LED stent. We don't leave like this. Once you've done putting a balloon in the left main to LED and then leaving left main to LED as after doing an IVUS, because after standing to the mid LED, the proximal LED was looking a little less. So it was a plaque. It was not a plaque free. So there is a high chances of progression of the disease in the near future. So it would have been better if we had ended with the left main to LED stent and doing crush with a circumflex stent and kissing balloon and then IVUS imaging of the both the vessels.
Actually, the way it was done, the LED left main balloon was inflated first. And then, as I understand, the circumflex stent was pulled back. Circumflex stent was placed in position with contrast injection, and yet it was pulled back. So this last few millimeters pullback we really don't know how much the stent is going to come back. It could come back in the left main. And in that case, you have no stent going from left main to LAD. So I would probably avoid this step. Whatever you have seen on the angiogram, that is your final decision. And don't move this stent with no contrast. It's not that the other thing was the LAD left main balloon was 2.5, which I'm sure is a smaller balloon for any ostial LAD and certainly for left main. So when you pull back, the balloon is not going to stop the backward movement of the stent. It has to be visualized. And that's why I would probably feel that this stent I wouldn't do and I didn't like, honestly. Sorry, Gurunath. I mean, Gurunath, you may have your own experience.
Dr. Gurunath is here to answer. There are many questions, sir.
Yes.
Dr. Hiramat, is he there? I mean, because
I have no idea.
I mean, because there are many questions. I also have got one or two. Right from the beginning, you can make out that the circumflex ostium is significantly diseased. I mean, it was not the later on he found. And our colleague rightly pointed out that, and you also agreed that in case of the acute coronary syndrome, acute occlusion of circumflex, why didn't he try? What was the explanation? Why did he try LAD first rather than going for the circumflex first? So, couple of questions. Dr. Gurunath, are you here with us to answer?
Thank you, doctor. The thought was, as Dr. Hiramat sir has rightly said, that LAD was a very large vessel. It was supplying the collaterals to the right coronary, and it was nearly closing. At the level of septal, you had a 95%. So I didn't know. I thought I should fix. Maybe, perhaps, in hindsight, I should have gone for the circumflex first. But that moment, I thought I should do LAD, and I went ahead with LAD. About the second comment, which is that whether I should have stented from left main to LAD during decay crush. I didn't think so for two reasons. First, the balloon in the left main to LAD was not big enough to cause any trauma to the vessel, because it was just 2.5 balloon. So it was too small for left main or even for proximal LAD. And at that time, see, this was slightly a panic situation. The patient having chest pain, then has EC changes, some arrhythmias. And at that time, I just wanted to keep LAD open. That's all. And so I decided to keep it with a smaller balloon. So even if I have, it just doesn't close, or doesn't have a significant stenosis, I should get away with the ostial circumflex stenting. Now, as Dr. Hiramat rightly he said, that there was a chance of the stent slipping back into left main. In fact, in the past, this has happened to me, that the stent has just slipped either proximally or distally. If you use a stent, if you use an inflating balloon to the 1:1 size of the main vessel, then there are chances of stent getting slipped distally. And if you use too smaller balloon, that is in the main vessel, then there are chances of stent getting slipped proximally. So this can happen, agreed. But as one of the shoot has not shown, in fact, the stent, when I pulled it back, it was exactly ostium. In fact, you can, that organic stent, you can see beyond the marker, the stent is seen, and the contrast was given and confirmed that it was in the ostium. And fortunately, later on also, the image is not there, but stent boost with contrast did show the stent exactly at the circumflex ostium and had not slipped into the left main.
No, Gurunath, the ostial circumflex.
So a good ostial LAD. So I thought I should, because this is, I didn't want to do in see, it was an ideal thing to do, but sometimes what I've been taught is ideal is the enemy of good. So the LAD was a good area, flowing well. And this, as you know, is not a very ideal patient also, 70 or I thought few years, symptom-free years in him, that should be okay. That's what my thinking that time was. Yes, ideally, yes, what you say is right.
No, Guru, I would feel you can place a stent at the circumflex ostium correctly without putting a balloon from left main to LAD. The balloon pressure can trigger a response in that area because you're not going to stent it. And so either you end up with a stent in left main to LAD, or better, not take this kind of balloon there at all and just focus on the circumflex ostium. Take many views, LAO-caudal, shallow LAO-caudal, RAO, shallow RAO, steep caudal. All these will probably give you an accuracy, and your eyes and brain, after so many years of in this specialty field, I'm sure you can trust them more than trusting a balloon in left main to LAD. So I would probably avoid that, and you're hurting the LAD area to some kind of balloon pressure. So we don't know the long-term future of this balloon. Luckily, it was a small balloon, but I feel the small balloon will not actually serve the purpose. I would have used a bigger balloon, and at a low pressure. As long as the pressures are low, it doesn't hurt the vessel wall. But if your size is small and you go high pressure, you are likely to hurt the vessel.
I just want to know one more point from the house, that suppose like in stents like this Onyx, there is a gap between the marker and the starting of the stent. So is it not good to take the stent in which there is no like gap, like using Zine's group of stents, especially for the ostium, so that you should not miss the ostium? Just I want to know the views of the house.
It is always better, Arush, to have marker to marker stent size. There's normally in other cases, there is 0.5 millimeter gap between the marker and the stent. So sometime in case you are using that kind of thing, you can miss the ostium. So always better to have the Zine's family.
Especially at the ostium.
Obviously, for the ostium purpose.
Yes, sir.
And secondly, Dr. Hiramat, what do you say? Because the circumflex ostium was clearly diseased right from the beginning. I mean, if you look carefully, and he was very lucky that despite getting so much of dissection, bad dissection at the ostium circumflex, he could manage it.
I would feel the opening of the totally occluded circ was important, and that Dr. Gurunath achieved very easily. And then you have to think how much you want to stent. And so many times we use this equation, not just the lesion length, but come back a little bit or go a little bit further down to if there is a big size branch and things like that. So on that front, I would have probably started the stent from the circumflex ostium.
That's right.
I am Dr. Panja here.
No. Having said that, if you see the ISR related to circumflex stenting, they are maximum if you have a stent at the ostium. So ostial is good, but ostial has to be done with great care.
Hiramot, Dr. Panja here.
Hi, Dr. Panja.
Yes. One thing is that regarding the pullback technique, actually Gurunath has done the well done, because technique is that you have to inflate the pressure and the lamens proximally very low pressure. He rightly inflated, but should be low pressure. Okay, and the circumflex to be pulled back so that some indentation will be marked on the balloon on the lemon stem. So therefore, one instruction is that it will low pressure inflation. That is the only thing. Other he has done the right job.
All right, Dr. Dilip Kumar is saying we should go to next presentation.
Okay, thank you.
And maybe we should go to next.
Thank you.
Very well done, Gurunath. We really enjoyed your case.
Thank you. Thanks a lot, sir.
It was very difficult because two vessels were occluded. One was acute, and the LAD was not at all an easy vessel. It had so many bends. So wiring must have been really challenging for you.
Thank you. Thanks a lot, sir.
Sanjeev, what is next?
Yeah, let's move on to Dr. Balbir's talk on latest from PCR EVC left main. Over to you, Dr. Balbir.
Yeah, thank you very much, Dr. Dilip, for inviting me to this symposium, and I'm going to present the results of EVC bifurcation. And we had some discussion of 1 or 2 stents, and you'll be shocked to see this one, because we were talking about, and I was showing an ostium disease, and we were thinking of 2 stents should come in. And we have totally different results from EVC main. So this is a beautiful trial, which is single, provisional, or planned 2 stent strategy. Lessons from the PC left main trial. So we know bifurcations involve 30% of PCIs. They have complex geometry. There is a side branch occlusion. Stent optimization, it can be an issue. Left main is a different animal altogether because of different sizes of main vessel, left main to the side branches. And more than 80% of all left main diseases involve the bifurcation. They have unique challenges of the angles, and 2 branches actually are 2 main arteries. 40% will be calcified. And we don't have great evidence to suggest which strategy is the best. So we have 1-year results from EBC main. This is important slide because patients who were included in this trial had unprotected left main bifurcation. What you need to mind is the Medina class 111 or 011. That means either both ostia are involved or both ostia are involved and left main. And this is something we need to understand. And we were talking of an OM, just osteal disease, and we were talking that it needs 2 stents. And now we are talking of left main with Medina 111 with a provisional strategy, not 2 stent strategy. So you have to understand that things are changing very fast. Everything doesn't mean a 2 stent. Every ostium disease does not mean 2 stent strategy. So provisional had about 30 similar numbers in planned 2 stent strategy and follow-up for 6 months, 12 months, and 3 years. The primary endpoint was death MI or TLR at 1 year. Our secondary endpoints were death MI and TLR at 12 months with angina status, stent thrombosis, death MI. Procedure endpoints was technical success, procedure success, in-hospital MACE, procedure duration, fluoroscopy, and the cost. So inclusion criteria, as I said, was Medina 111. Both vessels needed to be at least 2.75 or more to be included in this trial. The patient either had ischemic symptoms, positive non-invasive imaging for ischemia, a positive FFR, or a left main I was showing an area less than 6. So one of the things, criteria had to be satisfied along with the stenosis. Exclusion was the standard, no MI, no cardiogenic shock, no CTOs, no trifurcations. Stent diameter for the left main more than 5.7, again was patient's expectancy less than 12 months or known allergies. So they're choosing the second stent strategy. So the side branch in the provisional strategy was not treated unless there was one of the following. There was less than TME3 flow in the side vessel, severe ostial pinching, which meant more than 90. We have been always talking about more than 75. So they looked at more than 90 pinching as a use of a second stent, threatened closure, or a side vessel dissection. Under these circumstances, the operator was allowed to use a T-tap or a Couloud's technique. If you look at the procedural characteristics, we see radial procedure being done in 70% of the times in both the groups. A 7 French sheath was used in almost 1/3 of the patients. Antiplatelet, if you see, ticagrelor was in 20% and prazoquil in about 5%. So majority were on clopidogrel. GP2 inhibitor use was very low, bivalvurin almost none. Main vessel to LAD was 77%. Main vessel to circumflex in this group of provisional stenting was 23%. That means LAD was not stented. Kissing was done in some patients. So the preparation of the main vessel was 88% in both the groups. Cutting balloon, rota, lithotripsy. Lithotripsy was hardly used. Preparation of the side vessel in the provisional arm was also in 50%, which little surprises me in this group, but it was done, but we know they were involved vessels. Preparation was done in almost 83% on the 2 vessel stenting. Main vessel was stented and the side branch the main vessel was stented first in this group. In this group, the side branch was stented first because of different techniques being applied. And if you look at the other aspects of the procedure, kissing balloon after the first stent in the provisional strategy was 89%. So that means 11% no kissing balloon was done. Then second thing was the stent techniques. If the second stent was used in the provisional stent, it was culotte and tap majority. And if it was a systematic double stent technique, culotte was the main strategy. And you can see DK crush, very low numbers, 5%. Reason for a second stent in a professionals group was dissection, residual stenosis. Stent diameter on the side vessel was 3.5. So we were dealing with very big vessels, 3.6 here. A stent length on the side branch of the second vessel was 17.6 and 19.3. Kissing balloon after the second stent, if in the provisionals group, was done in almost all of them because there are only 22% who had the second stent. And in 93% in double vessels. So 6% ended up having no kissing. And I'm sure they couldn't do it. That's why it wasn't done. Port also was done in 80%. So not all had a port. Number of stents used in the provisional stent was 1.6 versus 2.3. Stent length was 25 versus 31. Procedure duration was a little longer in the two-stent strategy. So were the fluoroscopic time, and so was the radiation dose. So we come to the same slide that the port was in 85% of these patients. Now, if we look at the patient characteristics, the age group was around 70, males about 75 to 80%, diabetes 1/3, hypertension very high numbers, previous MI 26%, ACS 1/3 and an ACS. Syntax score was 22 or 23. Calcium moderate to severe, so this makes it a very high risk group. 44% in the professional group, and plan 2 stent strategy was 54%. Tortuosity was seen in about 19 to 21%. And now let's look at the Medina classification. Even in the provisional stent group, there is Medina classification of 1, 1, 1 in 90%. And in plan 2 strategies, 89%, and 0, 1, 1 is 10%. So when we are talking of provisional with plan 2 stent strategy, in this group of patients, we know both vessels are involved, and yet a single stent strategy has been chosen. Imaging was low use of imaging, 36% of IVUS in provisional and 31% in this group. OCT, 4% and 1%. So very low use of imaging in these groups. Now we come to the outcomes at 1 year, which was presented and published in European Heart Journal. So death, MI or TLR, 17.7% in the 2 stent strategy versus 14.7 in the provisional strategy. Deaths were no different, MI were no different. TLR was a little higher in the 2 stent strategy, stent thrombosis, no difference. So there was no difference in any of the primary outcomes. If you look at the time to first event, you see the maximum events happen within the procedure or the pre-procedure time. The 2 curves then start diverging at about 1 month, and they do not achieve any statistical significance at 1 year. So the curve up is the provisional curve, and the 2 stent curve is the below curve. What about the angina class? So everybody, both the groups showed a beautiful improvement in angina class. This is a Canadian CCS scoring. 1.8 to begin with and 0.4 at 1 year. So there was a very good improvement in angina class. At 1 year, the antiplatelets in 90% were aspirin. In the dual, it was 90%. The second antiplatelet was in 77 and 72% of these patients. So if we look at this data was 14.7% primary endpoint at 1 year, and SEC2 stent strategy at 17.7. This is very, very different from DK Crush 5 trial, which showed very low MACE rates in the stent strategy versus provisional strategy. Results are extremely different. And why they are different, we do not know. The primary endpoints were different. The population was different. The length of the lesions were different, but the results are dramatically very, very different. So summary, EBC main is the first randomized trial based on the EBC consensus of a philosophy of provisional strategy. And they still continue to believe that this is the provisional approach is still the best, even in Medina 111. And Onyx was the only stent studied in this trial. So why Onyx? Because Onyx has some advantages of being used in bifurcation. You can increase the size to the left main size. It's very good to kiss following an Onyx. The cells are bigger. So it provides all the good things that one needs for a left main stenting. So suppose you have a 3.5 LAD and you have about 4.5 or 5 left main, Onyx will go to that diameters quite easily. So that's why they chose Onyx and this group of patients and came to, if you look at the target vessel failure, the target lesion failure, the cardiac death, TLR, TVR, stent thrombosis, the event-free rates are quite low with Onyx. So it provides a good platform for a bifurcation stenting. So now let's look at one small case which illustrates how easy it is to open the cells of Onyx stents. So this is a patient which I did only 3 days back, so I pulled it out just to add to this presentation. So this is a LAD ostium with a big left main. So the LAD circumflex was normal. So this is an OCT image after 2.5 millimeter balloon dilatation. So you see a 4 millimeter LAD and about 5 millimeter left main. And this is after a cutting balloon of 4 and then a stent placement, which is an Onyx 4x22 Onyx to the LAD left main. This was kissed with a 4 millimeter balloon on the LAD and a 3.5 on the circumflex. And this is the result with the OCT image. You can see the stent has opened quite well. This is the final OCT image. You would see a well-expanded circular stent all throughout. We got a lumen area of about 11 to 9 at the ostium of LAD and 16 at the left main. And you see the cells. Now this is a 3D bifurcation. This is the part of the circumflex ostium, which has been opened by the kissing balloon. You see, have been able to remove all the jailed struts, which is a very important tribute for stent. That if you can remove all the jailed struts, you are less likely to have an ostium circumflex stenosis. And very easy to open this because of large cell design. So I guess this was not a trial which was Medtronic sponsored. Medtronic was asked to provide Onyx stents by the EBC. EBC also probably decided on these properties to use this stent for the left main. They could have chosen any other and asked this company to provide the stent. So it was an Onyx-driven trial of the left main and rather surprising results. So as we know, life can only be understood backwards, but it must be lived forwards. And this amazing results on Medina 111 makes us really ponder as to what we just look at 111 and say it is a 2-stent strategy. And this one brings out totally different from what we think.
Dr. Balbir, it was an excellent talk on EBC left main. And this endorsed our previous assumption that provisional stenting is better than a dedicated 2-stent strategy. But it's a data, you rightly mentioned that there is a big discrepancy between DK Crush 5 and this one. So what do you think if they had planned for the DK Crush as a default dedicated 2-stent strategy versus provisional stent, the result would have been different because the DK Crush was a 5% overall TLR and MACE as compared to this one, which is a double digit. So what do you think? Should they plan for a dedicated 2-stent strategy with the DK Crush versus provisional stent, and it would make a difference in that outcome?
So I guess nobody can answer this question. Nobody. One of the things against DK Crush 5 trial, it was done in centers which do TK crush very routinely, and very few centers were involved. This is a full Europe trial, and there was only few Chinese centers trial. So we'll have to watch very carefully as to what strategy of DK crush will it be superior. It's a good strategy. We use it very frequently, but it is to be answered. This answer is not there, and I'm very, very surprised actually that how our target, how a primary endpoint of 5% with DK crush to the left main could have been achieved, which is very, very low.
And second important thing is the imaging was done in 30% of the cases, 30-35% of cases, which is very contrary in this era. At least it should have been more than 70% of cases with imaging left-hand PCR. So
Right.
it was 30-35. Yeah.
So it was 35% IVOS and 6% OCT, which makes it 41%, which is a standard practice in Europe. So Europe, even this figure is very high for Europeans. There you use very limited intravascular ultrasound. So I wish if IVOS had been used, maybe the results could have been better. But even in DK crush, the IVOS use was 30 to 40%. So it was also not an imaging guided treatment of left main.
But the LMPCI trial should be with the imaging in 2021.
Can I make a point here?
Yeah.
So, stenting techniques and like 2 stent, 1 stent, and we have seen certain dichotomy. Like we consider biggest hindrance for the long-term outcome of PCI is incomplete revascularization. Now here in left main, we are leaving a circumflex ostium 70% disease, 80% disease. If it's flowing vessel, it's not it's a TIMI3 flow. We are not going to do anything on that. So we are leaving an incomplete revascularized vessel, which is more than 70-80% disease at circumflex ostium. So is it not a dichotomy? And second, we knew that what the result would come with EBC trial. The European centers, they they preferred doing a provisional stenting, and that's what reflected in the main result. It was a culotte in majority of the cases, DK crush in 5% of the cases. So everything was very clear right from the beginning. We could make out the result of EBC main a year back rather, that this is going to come provisionally better. So some dichotomies need to be answered in future.
Yeah. So first thing is that whatever logic sometimes teaches, the randomized trials do not go to the logic. So logic of watching a stenosis and opening with a stent may not be always the correct logic. So no randomized trial has ever shown, except DK crush 5, a benefit of, I'm talking of bifurcations, not left main bifurcation. These are the only 2 randomized trials, but many randomized trials have not shown 2-stent strategy better. So the EBC philosophy has always been that if you have a short lesion just at the ostium, you go and do a provisional strategy, keep the 2-stent strategy for a longer lesion, a longer length of lesion, or a very complex bifurcation lesion. So which is not a bad strategy. And to say that they had their results already in mind 1 year before presenting, I think that's not fair to the Europeans. They do a very good job, and I don't expect, in fact, I can say more to the DK crush part. These allegations can more be towards DK crush than to the EBC, because we know Goran Stanovic, we know Lefebvre, we know the kind of people they are, and they wouldn't go biased. So I think we should not question the integrity of this trial. It's a beautifully done and very conducted. In fact, it should raise many eyebrows and make us think several times before we put in 2 stents.
But I totally agree with Balbir's comments. Yeah, Shirish. Yeah. Just I was telling that I totally agree with Balbir's comments. It was a very nicely organized, EBC trial. And only thing, all the stents were Onyx because they have to have only 1 stent. So naturally they had to go for it.
Balbir, 6% did not get a final kiss.
Yeah.
Which I think is a lot of negative. I mean, I would probably expect just around 1% or 2% who do not get a final kiss, but 6% is a lot in my thinking. And that could hurt the final results.
So, Dr. Hiramat, you're talking about lack of kiss in the 2-stent strategy to 6%. So now let me tell you something which is, you will just jump. in the trial of left main, Clini just published the result in Euro intervention that patients who did not have kissing were about 20%, in which trial, in one of the major trials of left.
Excel.
Excel, right, Dr. Saibal, 20% did not have a kissing in Excel trial, and they compared it against the patients who had kissed and non-kissed, and there was no difference. This is really shocking, but it is there, published this year in Euro.
Right. So question of kissing is now question mark for clinical outcomes. Right, Excel trial has shown it.
So one more thing is
I mean, so many times you do OCT, you do IOS at the end of a two-stent strategy, and that decides, yes, you must go in for a final case, and then you do go for a final case. So to go back, like I always have a final case, no question about it, and I have
Dr. Hiramat, I fully agree. We do the same thing. We find if you're doing an OCT after the kissing, the stent struts, they just open up so well, and the deformity of the stent goes much better. So there is no question. I would totally debate that. But in a provisional strategy, kissing is still being questioned, and nobody has the right answer. And in the provisional strategy, with particularly the one, if it is not Medina 111, if it is an ostium of one and the other vessel does not show stenosis, and you have an optimal angiographic result, you may not kiss. But if you have Medina 111, kissing becomes nearly mandatory if you're using provisional or a two-stent strategy. I agree with you.
I'm not talking of provisional. I'm talking of two-stent.
It is mandatory.
Must get a kiss.
It is must.
So in two-stent also, these people had 6% no kiss, which I think is a failure of the technique or whatever.
Sir,
time is up, sir. We are running short of time already.
Okay. Would we use FFR in such cases? Like if we think that it is 70-80% or 90%, FFR is negative. Still, would you like to do intervention in side branch?
Sir, request all of you, the time for the session is over.
Okay, next section is on bifurcation only. So,
we can move on to the next presentation. We can move on to the next talk by Dr. Tan Chen Ting. Guide extension, its utility in real world.
Okay, I would like to share the slide.
नहीं जरूरत नहीं दो ठीक वो 9 बजे हाँ ठीक sure.
Oh, shit. Oh, can you see my slide? I'm sorry, I have some problem to share my slide.
Technical team, can you help us?
May I know what is the issue, ma'am? Please, you can. I have gave access to you, ma'am. Please click on
Okay.
share screen button.
Yep.
Raghu, you first stop your screen. Stop your share screen.
Yeah, madam. So please click on the shares. There's a green button on the bottom of your screen. Can you see that?
Yeah.
But Raghu, first stop your own shares, sharing the screen.
Sir, no, we are not sharing. We are not sharing.
No one sharing, sir.
No one sharing. We are not sharing. Can you click the green button, doctor?
Yes.
What do you see?
Actually, you can choose share screen, but the thing is, I'm using the new MacBook, so I have problem to share my my PowerPoint.
Can you immediately email this to us? We will share it for you.
Okay, all right. Okay, I can email to you.
I will write an email on the chat here.
Yep. Sure.
So in that case, we can move on with Dr. Hari.
Yeah, we can go to the next one, please, and let Chen fix it.
Yes.
Yeah.
Yeah, Dr. Hariom Tyagi, complex left bifurcation. Over to you, Dr. Tyagi.
Unmute yourself, Dr. Tyagi. Hariom, unmute.
Okay. His slides are visible?
It's Dr.
No,
Tyagi. Please open it. Please open it. Please double click your selected file.
Okay.
No, you have to open it. We are seeing your screen. We are seeing your screen, but we are not seeing your slide.
Open the PowerPoint.
You click the slide you want to show.
Can you just drag this presentation to your desktop, please? Can you drag this presentation to your desktop?
Yeah.
Yeah, please save it on your desktop and retry this again. Is your presentation PCR Asia 2020?
Yeah.
Yeah. So
just right click and open it. Right click.
The slides are moving?
no,
it
your
is not
slides, your presentation is not open, Dr. Tyagi.
Okay. Oh, yes.
Open the presentation prior to sharing the screen. First, you make it open before sharing the screen.
Okay.
Then you share.
Now, once you click on the green button, it will ask you what to share. So you can select that particular presentation that you want to share. Is the PPT open now?
Yes, sir.
That's it. So kindly go to the slide screen, the green color button at the bottom of your screen, the share screen button. Yeah, now it'll open. Yes, right.
Okay, sir.
Thank you, sir.
Thank you. Thank you, sir. Now it's okay?
Yes.
Okay, sir.
Yes, sir, it's perfect now.
Thank you, sir. Good afternoon, everyone. It's a great honor to be amongst you. Thank you very much for inviting me to this conference and giving me opportunity to present this case. Actually, this is not the same case I want to present, but due to some technical problem, but this is also an important case and interesting case. This case was 70-year-old diabetic male presented to us with complaint of this chest pain, associated with sweating, gabrat, and for last 3 to 4 hours prior to admission. His ECG shows T-wave inversion in diffusely in anterior and inferior leads. Echocardiogram shows severe LV systolic dysfunction, ejection fraction 20% with mild mitral regurgitation, and LAD territory shows regional motion abnormalities. His lab finding, hemogram and creatinine was okay, but troponin was present. His angiogram shows left main and
आशीष जरा वो एक डेलीगेट लिंक भेजना कोरोना ग्रुप एरिया को.
This was his ECG that shows diffuse T wave inversion both in anterior and inferior leads. Sinus rhythm rate is around 55 per beat.
98926.
And this was his angiogram. In caudal view, this shows some distal significant involvement. In LCX, this shows some haziness in the proximal segment of the LCX. And LAD is osteoproximal critical 80-90% lesion, and mid in shows some moderate lesion. This is cranial view. Is borderline 50-60% lesion in the mid portion and proximal significant lesion. Diagonal is significant branch, but the ostium is not open in this view. So this is caudal view. Caudal view shows some involvement of the ostium of the diagonal in this one. And also the haziness in the proximal segment of in the LCX is also there. Maybe this is a thrombus because the case with the troponin was positive. This was right coronary that was absolutely normal, but I want to make delineate this ostium of the diagonal before going planning for the procedure. So this was the allocranial view. This was the allocranial view, which shows the significant involvement of the left main in the, and also this LAD ostium is also shows a significant disease in this one. So this is distal left main. This is osteoproximal LAD, and this one is the large diagonal with ostial significant disease. So now we should plan the further regarding the procedure. So this is 70-year diabetic ACS patient. So our strategy regarding this procedure is first we have to decide whether we go for because they have the two side branches. One is the LCX across the left main to LAD, and one is the diagonal. Both are the significant branches. So the bifurcation strategy to be planned, and wires to be done to should be both vessels for the LCX and the diagonals. But before deciding whether we go for the provisional planning or for the two-stent strategy, we should assess the likelihood of the occlusion of the side branch. The LCX occlusions, this likelihood is less because the ostium is more or less okay, but the diagonal have significant lesion, and the ostium and the base, both the diameter and length of the diameter, this length is also significant. So we should plan this provisional stenting to this one. So in this case, we have angiogram was done through the distal transradial route. So because this is the bifurcation, so we have changed the route axis to the femoral axis, and the 7 French EBU catheter was taken, and wire both branches, diagonal and LAD. In diagonal, this is the cyan blue regular wire, but in this LAD, the cyan blue, and diagonal is BMW wire. So after wiring of the both vessels, the preparation of the lesion in the main vessel from left main to LAD was done with progressive pre-dilatation. First, the 2.5 10 millimeter semi-compliant balloon was taken to pre-dilate the LAD lesion, and then taken 3 millimeter non-compliant balloon to again upgrade the progressive pre-dilatation of the LAD and the ostium. And in the end, the ostium of the LAD was pre-dilated with a cutting balloon 3.5 millimeter. So after properly making the bed pre-dilatation, we have taken the stent well into the left main around 8 millimeter proximal from the bifurcation, and distally just covering the critical lesion. So we have assessed in the different view. So this is from left main to LAD. Distally, it was well into this normal segment here and proximally into the just proximal to the lesion around 8 millimeter proximal to the bifurcation. So after positioning of the stent, this is deployment of the stent, and after deployment we have taken this shot to whether the distal edge is okay, flowing LED is flowing good, diagonal is flowing good, and LCX is good flow. So first at the nominal pressure, this was 428 millimeter stent, drug-eluting stent that was deployed. And later on, after assessing this distal edge and side branches, this is the high pressure deployment around 16 atmosphere was done. So after deployment, this was the flow, good result. So before going further, we have taken this post dilatation with 4 into 12 millimeter balloon for the LED, and proximal optimization is done in the left main with the 4.5 into 8 millimeter non-compliant balloon. So after post dilatation or proximal optimization in the left main, so this was the post dilatation balloon. So we assess the side branch after the post dilatation. So this after post dilatation, the diagonal shows the significant critical lesion. But where we have 2 plans because it is elderly patient, 70 years, diabetic, and ACS patient, whether leave it or go for further treatment of this diagonal, because diagonal is around 3 millimeter in diameter and long vessels up to equally important as LED. So we have further this image functional assessment was done. This show the significant IFR. So before going to recrossing, we have this recrossing is done whether through the proximal crossing or the distal crossing. This is proximal crossing is better for this provisional without stent than because there's protrusion of this distal crossing is better for provisional because the protrusion of this struts into the main vessel in case of that, but in distal crossing there's the protrusion to the side vessels. And in proximal crossing, if we cross the side branch from through the proximal strut, then it protrudes, this strut is protruding into the main vessel. But in our case, side branch need to be fixed, and the strategy is reverse crush or internal crush in that case. So in that one, after proximal optimization of this proximal segment of the LED and left main, the struts are open, so struts to be crossed through the proximal struts in case of the internal crush collateral tap. So this is the balloon, the post dilatation balloon we can take through the boost, and we can choose the path through the proximal strut. So this is the guiding, like this imaging, it can help us to properly cross the proximal segment of the strut through the side branch. So after recrossing to the side branch, the pre-dilatation of the side branch ostium was done first with the smallest balloon. Then the progressive pre-dilatation was done through this 3 millimeter non-compliant, then the cutting balloon at the ostium. After the proper the preparation of the ostial bed of the left LED diagonal, we place this stent 3 millimeter.
The time is up, sir. For you, please.
This side branch was stented through this 3 millimeter stent. And after stenting, both balloon and wire are removed from the diagonal. So we have two strategy, whether we leave the gelled wire or we remove the both balloon and wire from the side branch. I am always comfortable to remove the both. So after removing, again post dilatation was done, and this recrossing, this post dilatation and crushing, after crushing of this side branch stent with the main vessel balloon, the recrossing of the same proximal struts to the side branch. The next step is post this pre-dilatation of this side branch struts. with the smallest balloon 1.25 and again with the large 3 into 9 millimeter non-compliant balloon. So previously this was the high pressure pre-dilatation to the side branch ostium, and this is the kiss, fast kiss. This is side branch with the nominal pressure around 10 to 12 and in the main vessel also 10 to 12 millimeter atmosphere. Side branch balloon was 3 into 9 and the main branch was 4 into 9. So after the kissing, this is again proximal optimization was done through this 4.5 into 8 millimeter non-compliant balloon. First is that the nominal low pressure in the left LED and the left main portion and proximally at the high pressure. So this was the final result after the procedure. So this case was done around in January 2017. And in last year in August, the check angio was done. Patient was doing good. This was the post procedure at that time. And this was after last year, after 3 years. Thank you very much. So we have provisional strategy first, and number 2 is the TK crush or crush strategy for the 2-stent technique. Provisional strategy till now, before coming these trials, this was safe for both patient and operator, and the long-term result is also better. Thank you very much.
Okay, beautifully done, Horiam. Very well done. And I was looking that you have done part 3 times, so it's easier for you to pass. Now, can you tell me that how you choose the side branch balloon?
What is it?
How do you choose the side branch balloon?
Side branch balloon?
Yeah.
For pre-dilatation.
Do you have certain criterion?
Yeah.
And kissing and all these things?
Yeah, side branch, because the LED is around 3.5 and side branch around 3 millimeter. So first pre-dilatation is done through the small balloon and later on with the cutting balloon 3 millimeter according to the size of the vessel, and in left main to LED ostial is around 3.5 cutting balloon. And later on stent was also taken 3 millimeter for the side branch. And for kissing we have chosen 4 millimeter according to the stent in the left main to LED. And side branch is the same, according to the stent, the 3 into 9 millimeter. And this kissing was done first was post dilatation.
No, I'm not asking about that. I'm asking about the side branch, because you know the side branch, the balloon shouldn't protrude much. It should just cross the ostium of the side branch. Okay, then you don't dilate the proximal portion too much and untowardly. So this is also from the bifurcation teaching from the EuroPCR group, that you should keep the balloon short balloon, and you should cross the ostium, but after ostium, you should be little projecting inside the main branch, not too much.
Yeah,
that's
it was
important. And one thing I was saying, it would have been better if you would have taken a 32 millimeter stent, because you missed the distal portion, just distal to the stent a little. Anyhow, that's all right, yeah. But everything was very well done and everything was meticulously done. Very well done. I must congratulate you for a beautiful case present. Thank you.
Thank you. Thank you.
Nice case. One question.
3 points. Number 1, I think the stent should have been a little longer so that you could have covered a little more length down and up.
Yeah, absolutely.
Number 2, what technique did you adopt for the side branch stenting? Whether it was a TN protrusion, because first stent was in the LED, then you went into the diagonal branch. It was TN protrusion?
It was internal crush. Around 2-3 millimeter protrusion into the main vessel and then crush through the main vessel balloon.
The TN protrusion would have been better because you need not to remove the wire and then crush it again. A little bit of protrusion into the main vessel and LED, and then you would have done a kissing, and without removing the wire. After a main branch stenting, you have removed the wire from the side branches. T and protrusion would have been a better number 2. Number 3 is imaging, because this stent in the left main part was looking a little under. You might have required a 5 millimeter balloon for that, because you were a little defensive because you are not a little more in the left main. Left main length was a little shorter. You should have taken a little longer stent. That would have been made a difference. This is what I feel.
Yeah. So always we should take a longer stent. to have the proximal balloon, even if you take a shorter balloon, there should be adequate space to cover the whole length of the stent in the left main.
Yeah,
So the length of the stent in the left main should be little longer.
Yes, yes.
Yeah, I was.
Pinching the circumflex, you would have a difficulty in the kissing from left main to iridium, left main to circumflex, because there are very short length available for the kissing in the left main. Had it been a plaque shift in the circumflex. That's the you would have,
I think.
But otherwise, you have done a fantastic job. You have done the pot 3 times absolutely as per the recommendations. But only thing was that if you would have chosen a little more longer stent, the things would have been convenient for you for proximal dilatation. Also, because you could have covered up the whole of the left main stent with the balloon.
I have
Even in
chosen
any bifurcation stenting, you should choose the stent in such a way that you have got sufficient stent length to have a balloon for doing the pot.
I have chosen 338 millimeter stent from left main to LED previously because the lesion in the mid segment is two tandem lesions. Both are not covered with 38 millimeters. So I have decided in the proximal bulb properly take the 4 millimeter stent, and if needed after the angioplasty, we can choose the second stent for the this middle segment if needed. But after procedure, I feel that the middle segment lesions were not significant, so I leave that one.
Dr. Sanjeev, I think we can move on with the next session. Dr. Chan Ten's presentation is not opening up. There are some technical issues. So we can have final remarks from the chairpersons and then we can move on to the next session.
Yeah, we had an excellent session. It's on a left main bifurcation. A few good cases. One from Dr. Dilip Kumar about the circumflex OM bifurcation, and then one from the good Dr. Gurunath. And both cases were excellent. And third one from Dr. Hariom Tyagi. All the three cases had a many learning points and required too much of time for discussion. But because of paucity of time, we had a very good discussion, and there was excellent data from EBC left main by Dr. Balbir Singh, and which also illustrated too much of discussion, and we had a very interactive and a very good session for this time. And congratulations, Dr. Dilip, for such a wonderful meeting. And now we can move on to the next session. Over to you, Dr. Dilip.
I thank the chairperson, the moderators, and the expert panelists for orchestrating a very learned discussion, which was a great benefit to all of us.